I talked about the premise that HER2 amplified tumors are addicted to that oncogenic pathway. And if you agree with that premise, then blocking that pathway completely ought to be really good therapy. Meaning that we might be able to get away with using only therapy that blocks HER2 and avoid chemotherapy, which of course is a lot more toxic. So first in the laboratory a number of years ago, my group published some papers on using combinations of HER2 targeted drugs to more completely block the HER2 pathway. HER2 is one member of a family of 4 receptors, and all of those 4 receptors connect together to stimulate the growth signal downstream. And Herceptin, or trastuzumab, the drug that we started using 15 years ago, blocks one of those members but doesn't block the others. And so we hypothesized that it would be more effective if you use more drugs to block the entire pathway. And we showed that that was the case. That led to clinical trials, which also showed for the most part that that's the case. And then we eventually did 2 studies in the Translational Breast Cancer Research Consortium, and other studies were done elsewhere. In Europe, the SOLTI group did the PAMELA trial, where we gave dual HER2 targeted therapy and no chemotherapy in a neoadjuvant situation. And we showed relatively high pathologic complete remission rate, ranging between 20 and 40%, depending on other characteristics of the tumor, suggesting that there may be a substantial group of patients with HER2 overexpressing tumors that don't need chemotherapy. They can be treated with much simpler, less toxic forms of HER2 targeted therapy, such as trastuzumab and lapatinib, or trastuzumab, maybe pertuzumab.